Professor Vivek. Thank you, IIP Neocon, Manoj, and NNF Kerala, IIP Neo-Chap, for giving me this opportunity. Professor Vivek, hi. So,
good evening. Can you hear me?
Yeah, we can hear you. And let me introduce Professor Vivek. He's a graduate from Bangalore Medical College, and then he went on to do his postgraduate from Belagavi now. He was from JLN Medical College, Belgaum, as his Cincinnati university profile is telling me. That time it was Belgaum, it is Belagavi. And then he did his from Westmead. You went to Westmead, sir, and then
Yes.
you went to Royal Infirmary, Leicester, and thereafter you did your residency in Cincinnati. And I'm so happy since 1997 you have been in Cincinnati. So it is one kind of a very good experience from one center that you have. So we are so happy to have you among us. I have kind of moderated or chaired one of your sessions in 2012, I think, in Neocon in Delhi, and I'm so happy I'm doing it again here in Kerala. Thank you, sir. Please carry on.
Thank you. Thanks a lot for that good introduction. Let me share my screen. Can you all see it?
Yes, sir.
Is it full screen?
Yes, sir.
All right. So good evening, and thank you all for inviting me to participate in this conference. And the topic today is role of budesonide and surfactant to prevent BPD. The question that was asked to me was, is this just a hype or hope? So hopefully by the end of the talk, I'll convince you that it's more of a hope than hype. Just a quick background information. You all know this. Preterm birth rates are anywhere between 10 to 12%, depending on which part of the world you are. Clearly, once you are preterm, you're at increased risk for mortality and morbidity. And then you know that it contributes almost to 35% of neonatal deaths. But the important thing is that these small babies, extremely low birth weight babies, are at the highest risk for BPD. Depending on how you define it, the most common definition for BPD is oxygen requirement at 36 weeks. Almost 60 to 70% of these babies get BPD. So that is why we're talking about this combination and to see if it will prevent this from happening. And remember, whenever we look at BPD, we also want to look at mortality, because mortality is a competing outcome for BPD. Meaning, if the baby dies, obviously there'll be less BPD. So you want to always look at it together. And we all know that once you have BPD, this baby is destined for the worst cognitive and worse pulmonary function outcomes in the long run. There are certain interventions that have been proven to be effective to reduce BPD, like delivery room CPAP, vitamin A, caffeine, volume ventilation, and postnatal steroids. But remember, they've all been shown to be successful in large randomized controlled trials. That's the kind of evidence we are looking for. This is just to remind you that BPD is multifactorial in etiology, but the core insult is inflammation, whether it starts prenatally because of an intrauterine infection or postnatally because of an infection, or the very act of initiation of mechanical ventilation or chronic ventilation can all cause pulmonary injury and inflammation. And what that leads to is a surge of pro-inflammatory cytokines that leads to a arrest in the lung growth and ends up with BPD. So what we're hoping to do is, with this combination strategy of surfactant and budesonide, to suppress this pro-inflammatory surge. A quick word on how the corticosteroids act. So when you give them corticosteroids, the corticosteroid gets through the cell membrane, then combines with the glucocorticoid receptor, and then this glucocorticoid plus the receptor, then as this complex then enters the nucleus, and in the nucleus it exerts some genomic actions, I'll talk about it, and some minor non-genomic actions. The genomic actions are in two ways. One is known as transrepression, where what it does is it downregulates the transcription factors which are responsible for pro-inflammatory release of pro-inflammatory cytokines. So it suppresses that. And on the other hand, it activates the release of anti-inflammatory cytokines by a process known as transactivation. And then it has non-genomic actions, which are minimal, but increases the synthesis of something known as annexin A1, which basically inhibits phospholipase A2, which then inhibits the pro-inflammatory cytokines. Overall, the goal of these steroids is to reduce inflammation. Now let's look at this combination of budesonide plus surfactant. So in this strategy, we're talking about giving this combination of drugs to babies at highest risk, right? So potentially, if you take babies less than 1,000 grams, because they're at the highest risk, we want to give it as soon as possible. Okay, that is almost prophylactically, we give this to high-risk babies. So let's look at the evidence for each one of these. So let's look at what's the evidence to see if prophylactic surfactant works, and then what is the evidence for pulmonary steroids. So pulmonary steroids most often is given inhaled, but we are talking about instilled steroids in this presentation, okay? So let's look at prophylactic surfactant. So if you look at prophylactic surfactant and compare it with selective surfactant, that's what we do nowadays, right? So we try and do delivery room CPAP. Then as the oxygen requirements keep going up, and when the oxygen requirements are the baby reaches a preset criteria, then we decide, okay, it's time to intubate and give surfactant. So let's look at prophylactic surfactant on its own. This is when you compared it to not giving surfactant. It clearly decreases air leak and mortality, all right? However, like I told you, when you compare it with selective surfactant, that is, you give antenatal steroids, you do CPAP, and then you do surfactant, what does it show? Basically, early CPAP plus selective surfactant is even better and reduces the risk of BPD and death, whereas surfactant by itself has no direct effect on BPD reduction. So as in today's neonatology, the benefits of prophylactic surfactant are no longer demonstrated, meaning we don't routinely give everybody early delivery room surfactant, either in the delivery room or even in the NICUs automatically. So what about the evidence for prophylactic inhaled corticosteroids? Okay, remember what we are talking about, the combination is instilled, but this is inhaled. So people thought, obviously, this is a better way of giving steroids because it has faster action, lower dose, and presumably safer. But the problem is delivery of the drug to the distal airways. Unless the size of the particle of the drug is less than 2 microns, it does not get to where it needs to and act. So whether you give it by MDI and nebulization, less than 1% of the drug gets to the distal airways. So there's a large trial done. That's the one in New England Journal called by Bassler. If you look at it, they did this early inhaled prophylactic corticosteroids. And then they showed that clearly it works, meaning the BPD and death decreased quite a bit. But the problem was there was a trend for increased mortality in the intervention group. And the other good thing was that when you look at long-term, there was no difference in neurodevelopment or death, because anytime we give steroids, we're always worried about its effect on neurodevelopment. There was no difference in neurodevelopment, but there's a concerning trend for increased mortality. So we don't routinely use prophylactic inhaled steroids. So far I've told you prophylactic surfactant, the way I describe it, is not beneficial in today's world of neonatology. We like selective surfactant administration. And I'm telling you, prophylactic inhaled corticosteroids are, again, not used routinely because of this potential increase in mortality. So what about, since we are talking about early steroids, I thought I'll just throw in the evidence for early systemic steroids. I'll just give it to you on one slide. So when I say early, it is steroids that are given in less than 7 days of age. So if you look at dexamethasone, that's the most commonly used drug. So if you give it in less than 7 days, clearly it again works, prevents BPD or the composite outcome of BPD and death. But the problem is it causes GI perforation, it causes CP, and the combined outcome of death and CP is worse. So as of today, we don't routinely use early dexamethasone. What about early hydrocortisone? Again, this meta-analysis is dominated by one large trial, but there are 5 randomized controlled trials. Again, it works. There's increased survival without BPD, meaning there's decreased death. But the problem is this also has increased GI perforation, particularly when given with indomethacin. And then it also has some increased incidence of late onset sepsis. But the reassuring part is that there was no difference in neurodevelopmental outcomes at 2 years. But based on the concerns of safety, we don't again routinely use hydrocortisone, early hydrocortisone, to prevent BPD. So that's why this combination comes into play, the mixture of surfactant and budesonide. The goal here is to use surfactant as a vehicle to distribute the surfactant to the distal airways and to cause a symmetric distribution to both lungs. This effect is known as a Marangoni effect, and I'll talk about it towards the end of the presentation. So basically, you want something to drag it down to where it needs to act, the steroid. So let's first look at the evidence in animal studies. If you take small animals like rats, mice, and rabbits, it clearly works. It reduces inflammation, improves gas exchange, and even on histology, it has a better lung histology. What about slightly bigger animals where we study physiology, like lambs? Again, it works. It decreases inflammation. There's decreased pro-inflammatory cytokines, not only in the lung, but again, in the liver and the spleen. So potentially suggesting that it also has a systemic anti-inflammatory effect. And the critical thing is that budesonide retained its activity in the presence of surfactant, and neither did it alter the surfactant structure or function, meaning both of them work as they're supposed to work. So let's look at some evidence in humans. So the first study was published in 2008. That's almost 20 years ago. Not 20, 14 years ago. So this was a trial done in babies with established RDS. If you look at the inclusion criteria, these kids were on mechanical ventilation and the oxygen was almost greater than 60%. And they used this combination of surfactant, which is Cervanta, a bovine-derived surfactant, and combined it with budesonide, which is about 0.25 milligrams per kilo. And then they showed there was a dramatic decrease in the combined outcome of BPD and death, almost 50%. No other intervention has shown this kind of dramatic response. So 8 years later, they went ahead and did a similar trial. This time it was a multi-center trial. The number of babies increased to about 265 babies. And again, these babies were on mechanical ventilation, diagnosed with severe RDS, and the oxygen was almost over 50%. Showed the same results. That's BPD and death is less, and severe BPD and death is also less, meaning that different definitions for severe BPD. However you look at it, it again worked. So then in the US, there is one center which does this routinely. I mean, they take babies less than 1,250 grams, and if they fail CPAP, they start with delivery room CPAP, and if they fail CPAP, they do this intervention. There's only one center in the US that does this. And we look at their data, they again do the same thing. They combine Cervanta with the same dose of budesonide. In this retrospective study, there was no difference in BPD or death. But however, there's severe types of BPD. There are 2 kinds of definitions. One is called the Jansen's definition, and the other is the NICHD definition. Both those decreased in the intervention arm. So if you put these studies together and do a meta-analysis, there is 43% reduction in the risk of BPD. The number needed to treat is 5. Likewise, there's a 40% reduction in the composite outcome of death or BPD. Number needed to treat is 3. These are huge. These are very low numbers for any strategy to reduce BPD. For example, if you look at delivery room intervention like early CPAP and selective surfactant administration, the number needed to treat is somewhere between 16 to 18, depending on which studies you put together in the meta-analysis. Likewise, vitamin A. This is a very, very effective strategy if it works. So the number needed to treat of 3 and 5 is unbelievable. So there are a couple more studies. I've given you references, more later meta-analysis done, but they've included small RCTs, another 2 or 3 very small RCTs, again, dominated by these 2 studies. And some people have also included inhaled corticosteroids, which is different from instilled steroids that we're talking about. So what is a concern with this combination therapy? Anytime we give steroids, we're always worried about this drug getting absorbed and causing effects on the brain, right? So we're worried about neurodevelopmental outcome. But luckily, only 4% of this drug is absorbed, meaning the systemic absorption is very little. The peak plasma concentration of budesonide occurs at about 30 minutes, and the level is almost similar to what you will achieve with just antenatal steroids. And then the metabolite peaks at about 2 hours, known as 16-alpha hydroxyprednisolone. The overall half-life is about 4 hours of this drug. There are potentially acute adverse effects that we're concerned about, like hyperglycemia, hypertension, increased risk of infection. All those have not been so bad. I personally have used this combination and I've found that we do see hyperglycemia requiring insulin therapy. And I'll show you some evidence for what evidence we have for long-term outcome. So, but you need to be cognizant of the short-term effects as well. So what about neurodevelopment? In long-term studies done by A and his group in 2016, he showed no difference statistically. However, there was a favorable trend for improved neurodevelopmental outcome in the intervention group. Likewise, the retrospective study from the US again showed they did P-body development in Bailey scales at 18 to 22 months, and again showed there was no difference in the outcomes, both of these showing that it's probably safe in terms of neurodevelopment. So these are all small trials. These are more to generate hypothesis and see if we can do a larger trial. So currently there are 2 large trials. The first one is known as the BIB trial, Budesonide in Babies trial. This is done by the NICHD in the US. They're going to enroll 1,160 infants. That's a huge number for babies less than 1,000 grams. Huge number of babies. This is a multi-center trial led by our own Dr. Ambal Namasivayam, and I am one of the PIs for one of our centers. And then there is another similar trial done in Australia called as the PLUS trial. Again, the plan is to include over 1,000 infants. They are way ahead of the US trial, and hopefully in the next couple of years, they should be out with their results. So the hypothesis in both these trials is very simple. In extremely preterm infants, that is babies at the highest risk, the intervention is early tracheal administration, like I showed you. This is instilled budesonide with surfactant. Compared to surfactant alone, and the outcome we are looking for is the physiological BPD or death, a combined outcome. And at the time frame is at 36 weeks, corrected gestational age. So the inclusion criteria, like I said, all babies less than 29 weeks. We include even 22 weeks. We include babies from 400 to 1,000 grams. And here, whenever a clinician makes a decision to give surfactant, that is the inclusion criteria, meaning it's not prophylactically to all babies. But if the decision is made to give surfactant, then they are enrolled in the study. And this has to be done within the first 48 hours. So the primary outcome is, like I said, the physiological BPD or death, a combined outcome. And the secondary outcomes, the whole list is here. We look at mortality, we look at mortality and neurodevelopment, we look at death and neurodevelopment, we look at NDI and death at 22 to 26 months. So there's lots of things we look at, and we classify by BPD and look at it. So, but the primary outcome is physiological BPD or death. Now, coming to the Marangoni effect, for those of you who are just waiting to join dinner now, as soon as my talk is done. So for those wine lovers, when you take a glass of wine and swirl it around, you see some spikes of the wine going up and down in the glass. They are called wine legs. If you've not seen it, try it today. Try and swirl the glass, and you see those legs going up and down, like a little spikes of the liquid going up and coming down. So essentially, wine is a combination of alcohol and water. So what's happening is that the surface tension of water is much higher than alcohol. So it kind of drags the alcohol up in the glass, and then due to gravity, it falls down. So those are the wine legs, and that's the same thing that is happening, this effect called Marangoni effect, when we use surfactant as a vehicle to drag the budesonide to the terminal airways. So this evening, but during a dinner, you can try this. So in summary, this strategy could be the most effective strategy we have to reduce BPD, severe BPD, or the combined outcome of BPD and death. I say might be the most effective because we don't have all the evidence at this time. So because we want to first make sure that it's safe. I think it's going to be efficacious, but the concern is the safety. So we want to make sure that the results, these big trials show that it is safe in terms of long-term neurodevelopment. So remember, the core clinical dictum is first do no harm. So please do not go into our units and start using this. Let's wait for both these studies to come out and published. So we're trying to get this to you as soon as possible. Hopefully the Australian trial should be earlier than the American trial. So with this, I will stop and take questions because I know you're all eager to get some dinner. Thank you.
Thank you, Professor Vivek. And it was very short and sweet. And it was actually giving very crisp messages to the audience, actually trying to feed to their appetite, both by knowledge-wise as well as by their the other appetites which you have invoked. And I think there would be a lot of questions. I think Dr. Manoj has already picked up a mic, and there are studies actually which measured interleukin and other cytokines in the tracheal aspirates in many of these studies as well. Anderson studies particularly on day 7 or so, day 3rd or so of after giving budesonide. Did it? Yes, there was some change.
Yes.
Or?
Yes. So this is being more clearly shown in animal studies, but in one human study, they've also shown that it decreases the pro-inflammatory cytokines.
And one of the studies, there was with the lower dose and dose escalation on day 1, 3, and 7.
Correct.
So that dose escalation did not find much of a difference. And in fact,
correct. That was done from in an institution called CHOP in the US. And yes, it didn't show. So it was hard for us to come up with the lowest effective dose. Remember, that's we want to make sure we don't give too much. And based on the lowest dose was basically, we derived from the animal studies. I told you the lamb studies, as well as the experience by that one center in St. Louis in the US. We decided to pick on this lowest dose. And we think this is probably the most effective dose, which is probably safe.
Did it actually resulted in some increased inflammation at some point of time?
In the animal studies or in the
human studies, did it resulted in some more of infection, sepsis?
No, not to my knowledge, not to sepsis.
Any questions? Questions, because this seems to be according to Manoj, it was more hype and hope. So he was dwindling between hype and hope, I think. And you have given us such a clear-cut, hopeful situation. So why hype? So we are waiting for the trials results, I think. Any questions from the audience? Tausif, please come. Tausif is a final year DM student from All India Institute of Medical Sciences, Delhi.
Good evening, sir.
Good evening, Tausif.
Yes, sir. So just wanted to ask about the question. Yeah. So like a single dose of instilled steroid having such a large effect and from 2 studies. So in evidence-based medicine, this seems to be more of a hype. And usually we are talking so much about the systemic steroid we give for like 7 to 10 days, the DART regime or the Premiloc regime, and we are finding that even the low dose steroids may not be sufficient. The medium dose dexa, methazone, and all have been proven to like BPD. And BPD being multifactorial, like to me, like a single dose of instilled steroid having such a long effect. All the steroids are known to have a longer effect. Single dose instilled along with surfactant having such a huge reduction in the BPD doesn't seem to be believable, although the studies are like so. So like,
you're absolutely correct, Tausif. That is our concern. We debated how can, like you said, it's a multifactorial etiology. And now we are suggesting, oh, this single bullet will treat or reduce BPD when even much higher doses of systemic steroids have not worked, right?
Yes.
So meaning it works, but it comes with a price. Okay, we don't want that price. And so this is, this was the strategy was questioned multiple times. How can you expect a single dose of a steroid to work? But we could not ignore those dramatic results shown in those earlier small trials. That's why I'm trying everybody to caution and say, don't get on the bandwagon and start using it. Exactly for the reasons that you said, that we are really concerned not only about the safety, but also, again, is this really going to be so efficacious? That's why the title is Hype or Hope. But based on this little preliminary experience that I have, I think it's probably tending towards hope, but I'm more concerned about its long-term neurodevelopmental effects.
As you rightly said, Dr. Vivek, that it was more, there was no composite, there was no difference in the BPD. But yes,
Correct.
there was a trend towards decrease in severe BPD. But if you look at the numbers of those severe BPD, there were 4 or 1 arm and 6 in 1 arm. So whether it was actually in the severe number, because there were 25 or 25 in each arms or something like that.
No, that you're referring to is the retrospective study that we don't, that is
with
not much
cohort.
Correct. So the retrospective is not something that you want to hang your hat on when you're doing such an intervention. So that's why we want a randomized control trial. So the 2 randomized control trials that have been done so far does show there's a dramatic decrease in BPD. Okay. At the same time, it shows that it's probably safer on the brain. So at this point in time, let's wait. This retrospective study is not something that we want to use to test its efficacy. We primarily looked at it to see, is it safe long-term, because they had data for long-term, right? So compared to the randomized control trial, the numbers were much more here. So we wanted to make sure that it's safe. So when we give this drug, back to Tausif's question, just 1 dose of that drug, 80% of the drug is there at about 8 hours. So it seems to stay there. And we believe it'll get to the distal airways, as I showed you, that it may get to the place where we want it to act and work. So I think from a physiology, pathology, there is hope that it might work.
Yeah, Dr. Ashish Mehta from Ahmedabad, Arpan.
Hi, Narendran. Vivek, now you mentioned about the budesonide and surfactant is a prophylactic thing. The trials that have shown the results. Trials that are happening are going to give selective surfactant. So again, how are you going to answer the question? Because we have seen the promising result with the prophylactic thing. Now
No, actually, Ashish, the 2 trials that I showed you, the randomized control trials, were actually given to babies with severe RDS. Remember, one was the first time the babies were in almost 50% oxygen, mechanically ventilated. The second trial, so this is established severe RDS, where the trials were done. But here we are talking about giving it to at-risk infants. So we still don't call it prophylactic, because I don't take all babies less than 1,000 grams and give it to everybody. We only give it to babies at risk who the physician thinks will benefit with surfactant.
But then the Pulmicort had that selective, or sorry, prophylactic surfactant. Am I right? Pulmicort trial showed the.
Yes.
Yeah. And that also showed the promising results.
The inhaled steroids was prophylactic, meaning they gave it from day 1. The inhaled corticosteroids, the article that I showed you in England Journal, they give inhaled steroids starting from day 1. It does show it works, but the dose of steroid.
Sorry, if I'm not wrong, Pulmicort was not inhaled. It was like given it through the ET at the first few hours of the life. Pulmicort trial.
Which one are you talking about? Can I go back on my slides and show you?
No, I'm talking about the Pulmicort trial, which had started with the budesonide and the selective prophylactic surfactant. Anyway, that's my
Right. No, Ashish, there is an inhaled one. So you can give it by a nebulization or MDI. But the dose there is much more. It's almost 25 times higher than what we are proposing in the budesonide, instilled budesonide trial. Okay. So if you look at the overall dose of budesonide here will be about 0.44 milligrams, whereas in the inhaled corticosteroid, I think that's what you're referring to as Pulmicort trial, they give almost 18 to 19 milligrams. It's almost 25 times higher. Remember, that's the trial that worked but had this increased trend for mortality. So that is prophylactic given from day one. Here, in this case, we're giving much, much lower dose compared to that large trial, which had over 800 babies in that bachelor study in New England Journal.
Sure.
So we give much less, and we're hoping that it'll work. And that's why Tausif's question is very important. So you're giving such low dose, and you think this one drug is going to cure your BPD. You know, that is an important question.
If any more question? Thank you, Professor Vivek. And we are fortunate to have the main organizers among us, Professor V.C. Manoj here. We would have loved to have you here. In fact, we would have loved to see how that Maragoni effect happens with the wine. You have wine available here, Manoj, tonight?
Probably yes.
Manoj, now.
All forms are available today. Okay, so Vivek sir, again, profound gratitude to you. As I always keep telling you, you are a hit every time you talk. It is so nice lecture, amazing information. The same information is probably a beginning of something. We will wait and see. So thank you so much. We hope to see more of you. Probably we should have had you in person here. It did not work out. Maybe next time. So this month we were fortunate to have 2 lectures of you. Neonatal dermatology. That was, I mean, like I still continue to get prizes about your talk on neonatal skin, not only from the neonatologists, from the dermatologists as well. So that is something and I believe that this is just a side by for you. Your main passion is neonatal dermatology, where your actual research is, and that shows. I think. And then this is again another interesting lecture. So thank you so much. Thank you so much for joining us. Now,
Thanks, Manoj. Thank you. Thanks for the invitation. So now you can all go enjoy your dinner.
Thank you. Thank you. This is the last session, but it's jam-packed. Thanks to you.
Thank you.